Welcome to this session on preferred practice guidelines in pediatric squint and neuroophthalmology. I welcome the expert panel, Dr. Pradeep Sharma sir, Dr. Arun Sampranti, SG madam, and Dr. Ramesh Kekonia, and Dr. Jyoti Matalia to come to the expert panel. And moderating with me is Dr. Kavita Kalaivani. I first invite Dr. Rajesh Prabhu, consultant pediatric ophthalmology, and strabismus at Shankara to present on intelligent diplopia management.
Very good morning to all. So the presentation for this day is diplopia management. So diplopia is a distressing symptom compromising the quality of the life, particularly in the practical field of fixation, which is going to be primary and reading position. So you need to have a thorough history taking before going into the proper evaluation of diplopia. You need to understand whether the patient is complaining of true diplopia or just a blur. It has to be differentiated between monocular or binocular, onset, frequency, direction, whether it is horizontal or vertical, torsion if there is any tilting of images, when is diplopia getting worse, whether in a particular direction of gaze or when looking for near, far or near, or when tired, to rule out myasthenia gravis. So let me take you through the next few slides about the systematic approach of a case of diplopia. The first basic step we need to do is to cover one eye to confirm whether you are dealing with the case of a double vision or a single vision. So diplopia, after covering one eye, still the patient complained of double vision, it is going to be a monocular diplopia. The immediate test needed is to do a small pinhole test, and still patient complains of single vision, it is going to be because of media opacities. Patients still complain of double vision, it might be because of retinal membranes and sensory causes. So when covering the one eye, patient immediately tells it is going to be single, then we are dealing with the proper case of a diplopia. So immediate test is to be done is cover test. So cover test will reveal either an orthophoria or a heterophoria. If it is orthophoria, it is going to be most likely a physiological diplopia. If there is a presence of an obvious squint in the presence of heterotopia, the next immediate test and the simplest test to do is the red filter test, which will give you the following observation, whether it is going to be a crossed exotropia, uncrossed, it is going to be esotropia, whether it is vertical or there is any tilting of images, which is going to be a torsional diplopia, or very rarely it can be a paradoxical diplopia. And then there might be special tests which might be needed in the cases of diplopia, which is going to be diplopia chart, Hess chart, and Belchowski's head tilt test, and sometimes 9-gaze measurements. And torsion has to be evaluated with double Maddox tests wherever necessary. So having evaluated the case of diplopia, now what are we going to do? The simplest goal is to provide a clear, comfortable, and single vision over as wide a motor range as possible. There are two ways of looking into it. Either try to fuse to a single image with the help of prisms, botulinum toxin, or surgery. Or if it is not possible for some reasons, at least try to eliminate the second image with the help of occluders and patches. So prisms is very effective in most of the patients, but only thing is it is effective only for a small comitant and incomitant deviations. There are two types of prisms, ground-in prisms and Fresnel prisms. The ground-in prisms is better visual acuity and better cosmesis, but the disadvantages being a waiting time for the manufacturing and dispensing, weight, expensive, and frame limitations for edges and shapes. Over to Fresnel prisms, it has a few advantages of restoring a comfortable single vision and allows a good depth perception, easy to change, and can be used in sectors as well, and it is lightweight. But the main disadvantages being a reduced vision, distortions, and reflections, and it is very obviously seen from outside, giving a cosmetic appearance. And fusion with prisms has been studied extensively in many of the publications, and it has been found to be very effective. The successful use of prisms is the careful selection of patients and patients' expectations. Only thing is needed is a good compliance and follow-up from the patients. Botulinum toxin is tried in many cases, and it chemically relaxes the unopposed muscle that is prone to contracture. This is the standard dose which is available in many of the textbooks. And Botox is not found to be of much useful in a long-term benefit in the cases of a diabetic or vascular origin. But in the cases of severe paresis of traumatic origin and intracranial pathology, definitely Botox helps. The advantages is being, in acute cases, it relieves double vision and prevent contracture, does not depend on patient compliance, and sometimes it can be combined with transposition procedures to prevent ASI. Surgery is needed whenever there is an indication. In comitant strabismus, whenever we are able to get stable measurements, we can operate. In paralytic strabismus, after 6 months, and wherever needed, adjustable suture techniques has to be used. The second important thing is to eliminate the second image. Sometimes being efficiently monocular is better than being inefficiently binocular. There are different types of translucent occluders available. And this is one of the glasses which is called Mintz glasses, where it is cosmetically acceptable what the above picture what the patient sees through the glasses. So the right eye vision is completely blurred. The bottom picture where there is no cosmetic appearance of that normal frosted glasses. Occluder and contact lenses can be used wherever necessary. In intractable diplopia, sometimes you might have to do occlusive IOLs to prevent diplopia. So in about the common causes of the diplopia are third nerve, fourth nerve, and sixth nerve. In third nerve palsy, prisms can be used in a partial palsy, not in total palsy. Botulinum toxin can be tried in partial palsy as well as isolated muscle palsies. Patching can be used when there is a bothersome diplopia. Surgery as and when indicated after 6 months. In a sixth nerve palsy, of course, chronic needs surgical correction, but in acute phases, sometimes in the waiting period of 6 months, we can use patching, prisms, or Botox toxin. Fourth nerve palsy, again, prisms and occluders and Botox can be used, and wherever needed, surgery can be advocated. And whether you are a patient or a treating doctor with double vision, it's going to be frequently encountering frustration. Only thing which we have to be very clear about is either make the patient comfortably fused or comfortably monocular. Thank you.
Thank you, Dr. Rajesh. While Dr. Rohit takes up his presentation on working up optic disc edema and distinguishing from pseudoedema, we can take a question or two. We'll have the questions at the end. So,
thank you, Dr. Murli, ARC, AIOS for the opportunity. Always a good place to meet friends. So I'll be talking about optic disc edema workup and differentiating it from pseudoedema, if this moves forward. Yeah. So the most important thing is knowing what is a normal optic nerve head. The key things to always look for, and our approach to the disc is a little different from the way glaucoma people talk about it. The shape, size, margins, cup, the neuroretinal rim, the vessels, and the peripapillary area, essentially in that order. But we are looking at the margins of the disc and not just at the cup. Although frequently cup changes have a bearing on how the disc appears. So the absence of a cupping either could be indicative of a very small disc and therefore the pseudoedema appearance, or else there is a true edema and the cup is now absent and filled up with fluid. So all these aspects of the disc we need to always look for carefully whenever we are identifying. And as one of my seniors used to say, you see a normal 1,000 discs before you start identifying abnormality. So stereoscopically see 1,000 discs before you start understanding the undulations and the elevations are normal or a part of a disc edema. So obvious disc edema would have a lot of signs which usually are not difficult to pick up, like loss of cup, elevation of the disc significantly over the rest of the retina. The margins are blurred. There is nerve fiber layer edema, and there could even be so much fluid that there could be retinal and choroidal folds. The vascular signs would be disc hyperemia, dilatation and tortuosity of the peripapillary vessels, peripapillary hemorrhages, the exudates that start getting evident as the fluid may get absorbed, and of course the cotton wool sign kind of things. So the mild edema could just be a blurring at the polar or at one edge of the disc, especially the nasal side, where the fluid starts collecting, and again it requires stereoscopic assessment and often may not be easy to pick up. You'll have to look for that little hyperemia in that area and the blurriness of the margins. As it progresses towards moderate edema, the entire disc, the vessels start getting obscured. One of the key things to look for is the vessel structure and appearance is absolutely normal beyond as it goes outside the disc, but closer to the disc it's getting partially obscured by the fluid and at the margins. And as the disc edema starts progressing, you can start seeing all the signs we talked about. Pseudopapilledema is an appearance of a disc edema when it is not actually due to an axonal swelling, and the vision may not be normal even in papilledema or raised ICT resulting in bilateral disc edema. The vision may be normal in early cases. The pupillary reflexes would be normal in both in early, but papilledema will start showing changes of visual function and pupil reflexes. The pseudo-papilledema disc would be a small cupless disc, but with normal vessels. But because the size of the disc is small, often there is not enough space for the vessels to bifurcate and divide inside the disc. That normally is a part of the disc, and therefore the vessels come up and then divide, and so you have thicker tortuous vessels on the surface of the disc. You can have abnormal branching that the vessels would show, again because they did not branch or normally divide as they would deep inside the disc as they enter into the globe. And of course, fluorescein angiography can be fairly helpful. Our approach to a disc edema, of course, would be whether it's bilateral or unilateral. So presence of bilateral, of course, eliminate or rule out a pseudopapilledema, confirm whether there is true papilledema and whether it is, so papilledema essentially meaning that it is probably due to raised intracranial pressure. Other causes could be diabetic papillopathy, malignant hypertension, occasionally bilateral papillitis, and inflammation, toxic, and again in adults, optic neuritis, bilateral, although less common. Hyperemic disc, if it's unilateral, essentially showing, meaning that the other eye or the other side of the eye is, normal. You look whether it's hyperemic or pale, although even in AION in the initial periods, the disc could be hyperemic, but over time you'll start seeing a pallid segment in the disc. A hyperemic disc would be papillitis, neuroretinitis, AION in the initial period, venous congestion. So just showing you that like how it was initially the AION, it was not looking so pale, but over time you can see as the other eye is showing you a previous evidence of pallor, which was a late stage. So patient presented with old AION and fresh AION in one eye. Just to show you, the OCT also shows you changes. So the one eye affected eye is showing you massive edema on the nerve fiber, and the other eye is showing you the loss of nerve fiber that occurs progressively with time. So these are the other way the OCT can tell you. One is, of course, you can look at the structure of the disc on the OCT and you will see the massive edema that you can see, plus the angle as the sclera approaches the optic nerve. There will be, because of the edema, this angle starts becoming negative and going further inwards towards the disc, showing that there is a lot of fluid in the retrolamellar part that is pushing the disc in front. So these are features that are suggestive of disc edema and true edema instead of a pseudopapilledema. These are all the various causes that can be mistaken for true edema: myelinated nerve fiber, tilted discs, hypermetropic disc hypoplasias. Buried and exposed drusen's are very important causes of pseudopapilledema, and you can see a lumpy, bumpy disc on it. And these are the OCT features. So OCT can help in identifying an optic disc drusen presenting as a pseudopapilledema versus a true papilledema. And as I mentioned, fluorescein angiography would show leakage in the early and late phase, whereas drusen's would only either show pseudofluorescence or, of course, may show a mild amount of staining in the subsequent period. Again, oblique inserted discs can appear like elevated disc or disc edema on the nasal part and can be mistaken for them. So essentially, good clinical examination and OCT can be helpful in differentiating true from pseudo disc edema and, of course, understanding the causes of true disc edema. Thank you.
If there are any questions for Dr. Rohit, he'll be leaving.
So then we'll go on to the next topic, managing optic neuritis. How have we evolved from the ONTT trials? By Dr. Muralidhar.
Okay. Sincere thanks to ARC for having me here. So I would be discussing some changes that we have incorporated on our practice since ONTT. So the principal findings of the ONTT, we all know that IV pulse steroids hasten the recovery, and So the principal findings of the ONTT, we all know that IV pulse steroids only hasten the recovery. There was no long-term benefit, and oral steroids were actually counterproductive. And the value of MRI was in predicting the MS risk. But we must remember that the ONTT was done in a Caucasian population, much different from the Asian population, and there have been some changes. So ONTT likely cherry-picked MS in a population that did not have the other variants like NMO and MOG as common, because they did preserve sera from ONTT patients, and none of them tested positive for NMO. 4 of them tested positive for MOG. So IVMP still remains the initial treatment, but the long-term strategy and prognosis are different. An MRI is required to prognosticate as well as to predict the chance of recurrence. And a number of additional antibodies have been are waiting to be discovered, especially 3/4 of the cryons. We still do not have an autoantibody that could pinpoint the diagnosis. So just an example, so we had a patient who complained of this gradual painless progressive decline in vision, and had a vision of counting fingers with disc edema. This was in the field, was in the normal this thing. So we have this thing. You have evidence of optic perineuritis and the intracanalicular segment which is involved. Rest of the brain was normal. So this is not multiple sclerosis, and the findings of the ONTT would not apply directly here. You need to test for anti-NMO and anti-MOG in a cell-based immunofluorescence assay. Any other assay would ELISA or anything would give you false positive and false negative assays. So but incidentally, this patient was negative, double seronegative. So we still do not have an autoantibody, and after 5 doses of pulse steroid had a complete recovery, but the central scotoma, complete recovery in vision, but the central scotoma still remains, and there is some disc pallor also. So this is a double seronegative optic neuritis, which again we do not know what antibody is going to crop up in future. So this patient, another typical patient, had pain during eye movement. So having burnt my fingers previously, even though the optic nerve functions, including the color vision and fields, were normal, we keep these patients who complain of typical pain elicited by eye movement and no orbital signs with normal corneal sensation. We keep them in follow-up for 2 weeks, because the ONTT did show us that the optic neuritis has a tendency to worsen over the first 2 weeks. The MRI was normal. So if the MRI is normal, according to ONTT, it is sufficient if you give pulse steroids, but here we have to test for anti-NMO and anti-MOG, and this patient was anti-MOG positive. So the way MOG differs in prognosis is that it is more common in children, can produce encephalomyelitis, and most importantly, if you do not give steroids, the outcome is not good. Even with steroids, though many people classify it as benign, the 4 patients in ONTT had severe disc pallor during the course. They had all received steroids. 30% of them have multiple recurrences. So first episode you treat with IV pulse steroids, but if you have a recurrence, you can give pulse steroids again, and if it sometimes it becomes steroid resistant. So for those patients, you have to either give IVIG or Plex. So I'll come to the treatment part shortly. So these are the clinical features. Male female is equal, and it's bilateral simultaneous, and hemorrhagic disc swelling can happen, and 1/4 of cryon is accounted to chronic relapsing inflammatory optic neuritis. 1/4 of that is accounted for by MOG. And you have, so we do not have a complete understanding. We do not as such have a MOG, seronegative MOGAD. So the treatment, there is considerable overlap with NMOSD. Here again we coordinate with the neurologist if if it becomes steroid resistant. So this patient was referred to me by the neurologist, and I thought it was possibly because considering the disc pallor, severity of involvement, and the age and severe ganglion cell loss in this eye, and acute right optic neuritis involving orbital and canalicular segment, I thought it was possibly an NMOSD, but turned out to be MOG positive. And eventually over a period of time with mycophenolate mofetil, the patient did recover 6/6, but the severe disc pallor and severe field loss persists. So it may not always be a fairy tale, and this patient had multiple recurrences required. This was also a MOG positive, had multiple recurrences, eventually became steroid resistant, and underwent Plex, and also was on IVIG, and now on long-term mycophenolate mofetil. We have managed to keep her above the water level, and she continues to retain a vision of 6/6. So this patient, after receiving the first dose, developed sudden painful loss of vision. So the guideline here is, this is also another optic neuritis, and this patient turned out to be NMO positive. Okay, so if you notice here, patient doesn't always read the textbook and come. If you notice here, there's only a short segment that is involved. So typically it would possibly be a clinically isolated syndrome, but we did test for anti-NMO and anti-MOG, and this patient turned out to be NMO positive. So if the patient is NMO, if the patient is either optic neuritis clinically isolated syndrome or MOGAD, you can manage yourself. If it is NMO, please refer to the neurologist, because many of these patients do not have a very great prognosis. So again, patient was not had any recurrence so far. So NMOSD is not giving a very steady, and some of them actually turn out to be good. But these are the criteria that was evolved by the NMOSD, and by the NMOSD group recommendations, nowadays we give IVMP for 5 days and not 3 days as was originally envisaged by the ONTT. So nowadays we give it for 5 days. So NMOSD typically has the worst prognosis among the three, that is typical multiple sclerosis, MOGAD, and this thing. So these are the criteria for NMOSD, and this is from Dutra's paper that shows the classic involvement. And I would just wrap up with this. This patient came with a pie in the floor appearance and had typical evidence of multiple sclerosis. This was the first episode, so we treated her with IV methylprednisolone and referred her to the neurologist.
Thank you, Dr. Murli. So now I call upon Dr. Ankur Sinha, please, to talk on taming the myopia pandemic. Yes, super.
Thank you, ARC, and thank you, AIOS, for giving me this opportunity. So the talk is going to be a little boring because the guidelines are usually boring. So we all know the definition of myopia, but we should also understand the definition of pre-myopia in children. These children have a likelihood of future development of myopia, and they have a refractive state of less than plus 0.5 diopters of hyperopia or more than 0.5 diopters of myopia. They also have certain quantifiable risk factors. Now, myopia is a global emerging health problem, and we expect that we will develop or maybe reach 50% by the end of 2050. Both globally as well as in India. So workup of a case of myopia is similar to what we do for a pediatric examination, but specific things to be taken care are the parental and the sibling history of myopia, the child's visual environment in terms of amount of outdoor activities, the amount of time spent indoors and in front of digital screen, and the lighting conditions at home and school. The history taking again is similar to what we talk about for pediatric ophthalm, but specific to myopia is age of onset of myopia, first classes prescription, amount of myopia, the history of pathological changes in the retina, history of progression, and if patient has taken any treatment before coming to us for control of myopia. The ocular examination again is similar to what we do for most of the ped-opthal and general exam for children, including the orthoptic workup, but we can add up axial length in terms of ultrasound biometry, but an optical biometer is more acceptable to children because it doesn't intimidate them when we try and measure the axial length for progression of myopia. Cycloplegic refraction is a must. For very young children, we can plan for atropine, short of which we can plan for homatropine and cyclopentolate, do a retinoscopy, AR can be done. Open ARs are now being propagated because they tend to minimize the residual accommodation and also the instrument myopia. They also help us in doing peripheral refraction, which is being advocated as a part of assessment in case of progression of myopia, and also try and document the myopia in terms of diopter per year. And ideally, we should try and implement the same method of refraction for a child whenever he comes for a follow-up. Now, must-do examination is the visual acuity, intraocular pressure, slit lamp, and the cycloplegic refraction. Good to do are the open field AR, axial length, binocular vision, and the tear film assessment. And exploratory refraction or a research examination would be a peripheral refraction, pupillometry, aberrometry, or a macular OCT. Now, risk factors for increase in progression are the environmental risk factors in terms of decreased outdoor activities, which is very common these days, increased near work, again, which is very common, and digital screen time, which we all are fighting for most of the kids when they visit our hospital. Younger age of myopia, higher baseline myopia, past myopia progression, parental myopia, they all can predict progression, but none of them can give you the rate of progression what the child is having. That is very, very personalized. Now, when to initiate anti-myopia therapy? Whenever the myopia is progressing at the rate of more than 0.5 diopters per year, for a younger child having a parental history. These are the indications when we should start thinking of an initiation of the anti-myopia therapy, but do not try and initiate anti-myopia therapy in case of ROP or a congenital cataract, because the mechanism here is different. The current modalities, whatever we have been evaluated for younger children between 4 to 6 years of age to up to 12 to 16 years of age. So do not try and initiate myopia therapy in a very young child or a very old child. Optical intervention in terms of spectacles are very good. We have always been doing, but now we have availability of DIMS, progressive addition lenses, and bifocal spectacles, specifically in cases of esophorias and accommodation lag. Some companies are giving these spectacles which are commercially available for dispensing. But the cost of spectacles is sometimes withholding for the child. We can also plan for orthokeratology or soft multifocal contact lenses, but we all know that multifocal contact lenses or orthokeratology, they have their own problems. And they may also need a spectacle backup when the child is not wearing these contact lenses. Low-dose atropine is one of the most easily acceptable and documented kind of anti-myopia treatment in the Indian scenario. It is a non-selective, irreversible anti-muscarinic agent. It is available in various concentrations from 0.01 to 0.1. Beware that the child doesn't take 1% because we don't want it. And 0.1% is commercially available and is passed by the Drug Control of India. And this can be used very commonly. I usually prefer to give them at a nightly dose so that they don't forget. Higher concentrations can be given if the patient is still progressing. But when we give higher concentrations, there are problems of near vision, and glare and photochromatic glasses and bifocals can be required in such cases. Low-dose atropine does have a rebound phenomenon, especially when the higher concentrations are used. We have to take care of the contraindications for use of atropine, and we should not be giving atropine in those children. Lifestyle modification is very important. Ask the children to go involve more in the outdoor activities, reduce the near work, decrease their screen time. Other measures like 20-20-20 rule, ambient lighting while reading, adequate posture, sitting on the chair table while reading, they are all helpful in reducing the myopia progression, and they are also helpful in pre-myopes so that we can reduce the development of myopia. Other points, like we should understand the children who have multiple risk factors, they need more strategic management and frequent review. One can maintain a myopia growth chart or a normal chart also, which can be kept. The duration of treatment is usually 2 to 5 years, and WHO limits it for 2 years. Again, for the orthokeratology or for multifocal contact lenses, again, the duration of treatment is 2 years. But yes, a longer treatment can be given if the child is progressing. We all know that some children do tend to progress despite our best efforts. So if they are progressing more than 0.5 diopters, it is called as progression. More than 1 diopter per year is a rapid progression. And the characteristics of non-responders usually are both parents being myopic, younger age, high baseline myopia, and previous history of faster progression. In such children, you can plan for higher concentrations of atropine, or maybe we can plan a combination therapy with atropine or DIMS or any other combination therapy we all know of. Now, when to stop? When the myopia stabilizes, a treatment period of 2 to 3 years. Whenever we taper the atropine and we find there is a progression of myopia, we may think of recommencement of the therapy, and switching from one therapy to another can also be considered when the myopia is progressing. So I think that's all we have in the present day for anti-myopia. Thank you.
Thank you, Dr. Ankur. Now I invite Dr. Aruna Radhakrishna to talk on newer trends in amblyopia management. So we'll have the questions at the end. எல்லாருக்கும் மாத்தி மாத்தி நம்ம क्वेश्चन கேட்டலாம். சரிங்களா? ஃபர்ஸ்ட் நீங்க
Good morning.
RP ஓட क्वेश्चन சார் கிட்ட கேளுங்க. அடுத்து
Let's have a look at the newer trends, amblyopia and preferred practice guidelines for the same. So, though amblyopia research has been dated as early as 1700s and has been constantly evolving, until recent years, conventional patching therapies were the only option available. And as you all know, it has its own limitations. So, like what happens when conventional patching therapy is done, as you can see in this picture, there is only a quantitative improvement of vision, but there is a false orientation, in this, as you see in the second picture, and there is no binocularity. There's a false orientation of the image. So that's the main limitation, because we all know that it's a binocular vision disorder. So then came, with the recent advances came the newer vision therapies. These therapies were based on 2 learning concepts, perceptual learning and dichoptic training.
Pradeep Sharma sir.
So perceptual learning was defined by Eleanor Gibson in 1963 as an experienced dependent enhancement of our ability to make sense of what we see, hear, feel, taste or smell. And these are the some other forms of perceptual learning for other senses. So coming to perceptual visual learning, it's a repeated challenging visual task which is done with Gabor's patches, and it increases the visual threshold acuity levels, and as the difficulty of the tasks increase, and this strengthens the neural connections and rewires the connections in the brain and leads to visual improvement. So the next is the dichoptic training. The basis for this is we all know that amblyopia is a binocular visual dysfunction with monocular deficits, and suppression is the main gating mechanism here. So the aims of dichoptic therapy are to eliminate suppression in the first line and to strengthen fusion and restore the binocularity of. So this is the eye which is treated with the binocular newer active vision therapies. You can see there is a improvement of the visual acuity, and there is a true orientation and restoration of binocular vision. So coming to whom to consider for these active vision therapies, all types of amblyopes can be considered, but the functional refractive amblyopes, they have a good prognosis. Some therapies do work for organic causes of amblyopia. And age groups 5 years and above are ideal candidates for these therapies. However, children as early as 4 years can, if they are able to perform these software-based therapies, then they can be taken up. And visual acuity, again, it's 5/60 or better, but some therapies do work even for lower vision patients, and it can be customized as per their needs. So for going into this vision therapy, a comprehensive eye evaluation has to be done, which is like vision and refraction has to be done, a motor and sensory evaluation, and of course an anterior and posterior segment examination to rule out any active pathologies happening there. So, and most of these therapies require a foveal fixation. It can be done either with an ophthalmoscope or a OCT image. So based on the literature and our own experience, the preferred practice for these new therapies is, first you have to accurately diagnose an amblyopia and classify them, whether it's a functional or an organic amblyopia, because treatment varies between the two. If it's a functional, we all know you have to treat all the amblyogenic factors and give them the best optical correction where possible. And in functional, there are two therapies, as we already saw. It's a perceptual learning based therapy or a dichoptic training. Both can be given customized to on the patient basis. And for organic, like low vision patients, we can give a try of perceptual learning programs. And we of course, for all these things, we have to monitor during the therapy, reassess, and follow-up of the patient is very important. So just have a look at the software options. Revital Vision is a perceptual learning-based program, which can be done both for organic and functional envelopes. And Binox is a dichoptic anti-suppression software. It's a user-friendly software, and it works well with all amblyopes, especially refractive amblyopes. So Vishwa Prime is another by Shankara team, which has a home edition and a professional edition, where the patients can perform at the office. And then this is again a dichoptic anti-suppression based. So the other VR-based and mobile-based therapies are DIGRUSH, VTSO4, and Vivid Vision and Pauling blocks. So the take-home message is you have to identify amblyopia and you have to customize the treatment regime for each patient and monitor them during the therapy, assess the endpoint, the duration of therapy, reassess and reevaluate them, and follow-up of these patients. And these are all the guidelines, but it has to be updated regularly, and we have to take this only as a guidelines, and on basis of each patient, we have to customize the treatment options. So newer therapies are desirable and should be encouraged. However, needs regular updation. And thank you. Thanks for the podium. Yeah.
Thank you, ma'am. Now I request Dr. Sumita Agarkar, ma'am, to talk about adjustable sutures in strabismus surgery, indications and techniques.
So, good morning everyone. I'm going to talk about adjustable suture techniques. So, why adjust in the first place? It's desire for precise results in face of imprecise measurements. So, certain situations where we don't know what we are going to get, it is probably good to have this technique in your armamentarium. And of course, sometimes some surgeons do prefer that as their preferred way of dealing with strabismus, and that's also fine. What are the cons? Long-term stability of alignment is still a bit of suspect. And yes, patient has to go into the theater or has to have the procedure a second time. In children, it becomes difficult. It requires second anesthesia or at least a propofol. So that becomes a little bit of a problem in children. So is there any evidence that does it really work the way it is supposed to work, what we theoretically feel that it is better? So in a review of 2013, there was no RCT data available. There was no evidence to reliability saying that adjustable technique was better. And at that time, there was a scope of RCT with the two techniques. But a recent 2020 review shows that there were two RCTs done comparing the two techniques, but did not find any difference in the outcomes. Reoperation rates were slightly better in people who used adjustable sutures, but they were significantly better compared to those who were used, surgery was done non-adjustable technique. But outcomes, as far as outcomes were concerned, at 6 weeks outcome, both the RCTs did not show any great difference. There was a difference, but it did not reach statistical significance. So that means it works in some people and it doesn't work in other people. So is it good for everything? So this is an old review. Again, this is a very large study. That's why I'm putting it here. So reop rate was 8.5 in adjustable and 27.5. But the newer RCTs don't show this greater difference. But again, the same thing. Reop rate is where there is a significant difference, but there was no difference between in outcomes as far as concerned. So then it comes down to what is your personal preference. So when to adjust, these are the situations where you probably want to have this technique in your armamentarium. These are the places where patients are likely to be diplopic, incompetent angles, and they are likely to be unhappy with the traditional surgery. How you would do it? There is a sliding noose technique, there is a bow tie technique, and there is a newer with Nihalani et al. Producing a short noose technique. Advantage of a short noose technique is that it does not require too much of manipulation, and it is much easier to manipulate in a very and it doesn't require any sedation or anesthesia. So more than 15-year children can have the benefit of adjustable suture, but in children, before you offer, you should probably try to do a Q-tip test or at least applanation pressure in children. If they are allowing you 80, they're probably likely to allow you. I'm talking about between say 12 to 15. More than 15, most patients do cooperate. Anesthesia can be general, local. Avoid bupivacaine because it has a longer anesthetic effect on the muscles, and it can be done under topical too. Sometimes in children or younger adults, you can use a combination of midazolam and fentanyl. And in children, sometimes you can combine a topical with propofol also. So when to adjust? Ideally within 24 hours under topical anesthesia with full optical correction in place. There, Dr. Sharma has reported he's here, and he has reported good results with single stage adjustable, and it probably is something which you should consider in adults, although they have reported a slightly higher incidence of OSR. If you don't know, if you're a new surgeon, is it adjustable for you? Yes, you can use a tandem adjustable suture. Requires 2 extra sutures, 2 fixation points, one through the muscle like fixed at the sclera, and another through your stump like an adjustable. So if you are very confident about what you got, all you have to cut out is the one which is passing through the and leave it in fixed at the sclera. And if you want to adjust, you cut the fixed sutures and pull up or pull back using your adjustable hang back. So this is also something you can do in a new. Endpoint of adjustment, probably a small ET for intermittent exotropia, a small ET or on point for sensory exotropia. Accommodative esotropia, you probably want to leave with a small ET only. I think there is a small mistake. And esotropia, you probably aim for just ortho or little under. These are the complications can happen. These are common for any strabismus surgery. Nothing special with the ortho, but suture related granulomas are a little bit more common because you are going to leave a longer length of the suture. So what are the practical pearls? You should probably have a bucket handle suture to keep it, to use a muscle to manipulate the eyeball when you are adjusting, because sometimes that becomes painful and when you want to little bit. So having that suture which is just kind of a loop through the sclera, it helps. Your assistant can move your eye with that using a bucket handle without touching anywhere in the eye. It is relatively easier to pull up the muscle than to push it behind. So sometimes it's probably better to leave them a little more than what you anticipated. Limbal incision gives better exposure, better closure, and better easier for adjust. But short noose technique you can do very successfully with a fornix incision also. Beware of the oculocardiac reflex and keep the anesthetist in hand, nearby at least. And conjunctival closure sometimes gives you a small recession effect. Do not plan very large recessions on adjustable because they don't work very well. Thank you for your attention.
Thank you, madam. Request SA madam to come and talk on managing drug-induced optic nerve toxicity while SA madam is getting ready. I have a question for Sharma sir. Sir, this debate of adjustable versus conventional has always been there, and single stage versus two stage. So, your comments, sir?
Is it on?
Katya.
No, basically, I say that adjustable is a technique which one should learn, and if required, like very demanding cases, you may do it. So I also do it rarely. And a single stage, of course, we did it as a study, but basically two stage is the one which I would say is more practical. And intraoperative adjustment, of course, you would do at the time of surgery, but that is not, perfect, because you are doing it on the basis of what you see, the eye positions. But two stage is the one which we do it for cases which are very demanding, which have diplopia and which will be like creating a problem otherwise. So whenever you have to, then you may do a two stage surgery, but mostly it will be like maybe less than 1% of cases you will be doing an adjustable.
Good morning, everyone. I am going to talk on managing drug toxicity of optic nerve. So if you know that it is a drug toxicity, there's nothing to manage. Just stop it. And I think that's the treatment. Okay. I'm done with my talk. So toxic optic neuropathy is visual impairment due to optic nerve damage caused by a toxin, which could be a drug. So the papillomacular bundle damage is the most common cause why you get a ceco and centrocecal defects. And patients don't reveal this history because most of the times they think that that history is irrelevant to their visual presentation. So you have to pull out that history of having that drug, which is the causative agent behind the vision drop. So identifying the causative drug is a key for the toxic optic neuropathy because it presents painless, progressive bilateral visual loss. So you have to be careful when a patient presents like that, and color vision loss is usually disproportionate to the vision loss, and it can range from a relative scotoma to total blindness. Most commonly they present less than 2400, and bilateral presentation causes a bilateral sluggishly reacting pupil. And RAPD is very, very abnormally seen, particularly in an asymmetric presentation, you may end up seeing it. An optic disc can be normal to swollen to or hyperemic. Sometimes we can see even disc hemorrhages, and temporal and diffuse pallor are the most common presentations. So disc chromatopsia is the first symptom, particularly the red disc saturation. And remember, toxic optic neuropathy is always a diagnosis of exclusion, and you have a whole list of these differentials for you to come before making that diagnosis for that patient. And the common causes of toxic optic neuropathy, coming to the drugs, are this huge list of drugs in which I have highlighted the most common drugs which we see in our day-to-day clinical practice. And maybe I'll try to show some examples of those also. And do a detailed optic nerve function test as shown here. And maybe you can add electrophysiological tests, OCT, visual fields, Amsler to aid the diagnosis. And as I mentioned, because it's bilateral presentation, do not search for a relative afferent defect. It will be a sluggish response in both the eyes. And VEP can have a normal latency at times in the early stages, but it has a grossly reduced amplitude. And ERG, it can be both full field as well as a multifocal. Remember to use a multifocal ERG when you are suspecting a retinal toxicity versus an optic neuropathy in a central scotoma. So this is I'll be showing few cases. In this, the first case is a 44-year-old female who came with the complaints of progressive drop in vision in both eyes over 2 months. She had 3/60 vision with a dropped color vision, bilateral sluggish pupil, and anterior segment, and the fundus was almost near normal. And there she gives this history. So she was on ATT and she has stopped recently over 10 days back. And this is her visual fields. You could see a dense central centrocecal and which is predominantly in the temporal quadrants. And yes, that's a toxic optic neuropathy secondary to ethambutol. So ethambutol toxicity is quite common and it gets missed also. So we stopped the ethambutol and her vision improved within 3 months to 6.7.5 to 6.9 in both the eyes, along with the improvement of the visual field. So ethambutol toxicity can happen almost in 6% of patients on ATT. It's dose dependent and duration dependent, so watch for it. And most common visual fields are, as I said, and we can see also a bitemporal defects in few of them. And prompt discontinuation should lead to an eventual visual improvement mostly, but what we have seen is a gradual pattern of recovery in our patients. And this is a study which we did in our institution, and we found that the ocular toxicity was quite higher in elderly, with low BMI, with immunocompromised status and poor renal function. And remember, it has a very gradual recovery pattern. So just keep the patient in a close follow-up with supplements. So this is case 2 who was referred as an optic neuritis. He was a 53-year-old male. He had a drop in vision in left eye for 2 months. And he had some cardiac ailment for which he was on treatment. He didn't carry the reports. He was in hypertensive. And by the time I saw, he was already post-IV steroids. So this was the vision, and this is the disc appearance. He came with the left eye presentation, but you could see the right eye is also not normal, and he's having an inferior defect with a color drop, and pupil is still sluggish, and he is totally unaware of the right eye. He came only with the left eye. We did a complete atypical workup, and then when we went through the reports, this was the added drug for him in the last 6 months. So he says that probably he had some drop in the right, which he was not very symptomatic. You have to remember about this drug when you see patients on cardiac problems, because it's very difficult to differentiate an amide or an optic neuropathy versus an NAION because they have the similar risk factors. So this is one differentiating: male preponderance, insidious onset. You will see a normal to large cup as opposed to a crowded disc in an NAION. It's mild vision drop. The patient didn't even know that he had a drop, and it's a protracted disc edema. I saw the patient after 2 months still sitting with a disc edema. That is one thing which is going more in favor for an amide or an optic neuropathy. This is a third case who he was being treated for TB for years because he was a MDR TB. And this time he came with a 2 months vision drop. He had bilateral drop, bilateral color vision, and both the pupils were sluggish. And this time he was on this second line drug treatment because he has already completed the first line and he is senior in the treatment. So now he's moved on to the second line. So this is the disc. So he had a very crowded, very subtle disc, but still it was pink. And you could see that central scotomas in both the eyes. And here the culprit was linezolid, because the patient was on the second line. Remember, linezolid is always given as a second line therapy in our TB treatment. And this is after stopping the linezolid, there's an improvement in the fields. So linezolid usually is given as second line drug, and it causes its toxicity 5 to 10 months later. And most of the times by stopping, you will have an improvement in the vision, but we see the visual field effects persisting for a longer period of time. And it is a mitochondrial dysfunction. And if you remember, even a patient who is on linezolid is prone to develop Leber's hereditary optic neuropathy. A patient who is already having a tendency to go in for mitochondrial dysfunction, it will just aggravate if he is going to be put on linezolid. So this is the last case who was referred to us as an optic neuritis again. and she had a bilateral drop in vision, but she was too symptomatic. If you could see this, it's a very subtle temporal pallor and a very minimal field loss, but the patient was very symptomatic. So the patient was actually referred to us for the second line of optic neuritis treatment. But looking at this fields and the vision, I said, no, there's something else which is going missed. And her VEP was also having a reduced amplitude, and that's the ERG. She had a bilateral gross reduced scotopic and photopic responses, and MFERG is also showing a gross foveal parafoveal response reduction, and that's when she gave this history. She was on chloroquine for a longer period. She was having frequent episodes of fever and joint pains, and that's the chloroquine toxicity of the macula and not an optic neuritis. So remember, differentiate all these factors. So while most of the drug-induced optic neuropathies can reverse when the offending agent is discontinued, there could be some amount of visual loss which is persisting, and the detailed drug history is very important. Remember to note down the dose and the duration, and always a bilateral progressive symmetric vision loss. You have to consider drug toxicity in the differentials, get the history out of the patient, and a contrast enhanced MRI may be required at time to rule out the other causes. So identify the agent and stop it. That's the treatment. Thank you so much.
Thank you, ma'am. Now I call upon Dr. Sahitya Bhaskaran to talk on diagnosis and management of cerebral visual impairment in children.
Good morning. Thank you for the opportunity. I'll be talking on cerebral visual impairment, diagnosis and management. I'll try to cramp it within 6 minutes. So the evaluation from routine pediatric is different in the sense that you'll have to do a thorough medical record review for other problems and perinatal problems that are in the child and the drugs that the child is on. And also observe the child when the child comes into your clinic. An interview from caretakers, the specialists is very important. With a standard ocular examination and best corrected glasses, a functional vision exam is mandatory in every child with CVI. So points of interest in visual acuity, it should always be age and ability appropriate, because these children do not cooperate well with you. A fixing following is not enough. Always try to get a preferential looking acuity. Distance visual acuity, it will always be done, but near visual acuity we don't do in children that often. But in these children, a near visual acuity is what is important, because rehab starts from there, and that is the vision that the child is going to use. Accommodation is very important in these children, because they'll always have some problems with accommodation. A simple dynamic retinoscopy will tell you if they have an accommodation lag. If there is an accommodation lag, they will have to go in for a plus glass. Most of children with ASD and ADHDs will have a lead of accommodation, while others with CVI typically have a poor accommodation. And for every child that you assess, always look at the latency period, meaning the time that the child takes to respond to a test, and that time period or latency period should be given for every single test to allow the child to respond. Remember, always present single optotypes. If you're worried about amblyopia or you want to know the interocular difference, you can use single optotypes with crowding bars. Do not ever convert grating acuity to optotype acuity values. And the most important point here is the functional visual acuity for every person, be it typical or CVI or vision impairment, is always 2 to 3-fold larger than the actual measured visual acuity. Meaning, if N6 is your threshold, if the smallest font that you see is N6, you would not prefer to read N6 throughout your daily life. You would rather prefer a reading font of N10 or N12. That is what these children also do. So if they measure 612, don't keep presenting them 612. You have to go for a 618 or 624 as a functional working font. Functional vision assessment. Contrast is very important, because that decides your communicable vision. The visual field, despite the central visual field, inferior field is always affected. So always look for the inferior field. Discrimination, ocular motility, visual guided search for optic ataxia, and simultaneous agnosia. These children cannot process two things at one sense, or they cannot do two senses at one time. Meaning they cannot see and talk, or they cannot see and hear. So always differentiate with one sensory input. The intervention, the aim of intervention is to reduce the visual disability and to minimize social disadvantage. So basic principles, everything should be clutter free, boring background, solid shades, always assess with best glasses. The ambient room lighting is very important. It is not that these children should be put in dark rooms. Ambient room lighting is what is ideal. Sometimes they do well with low illumination. And functional vision assessment is mandatory. They need breaks, so always give them their breaks and include the entire caregiving team. Glasses always should be given. Any refractive error, because these children are very small, do not go by APAO guidelines, Indian guidelines, all that doesn't work. Any refractive error should be corrected. Reason being, improves clarity, improves magnification. Children with hyperactivity, they work as peripheral blinders and cancel out the peripheral fields. Accommodation also they help with. And again, please note down the functional visual acuity for all practical purposes in these children. Environmental modifications, the 3Ds, depending on the developmental level, diversity and duration, use plain backgrounds, the ambient lighting, and simplify the visual array. Always give what contrast they have to work with, where should they be seated, and the important writing materials for learning and in school. Visual field, when you have a lower visual field, this decides the mobility. So always make sure there is a suprathreshold stimulus, because visual field is a relative field in these children. So if you use a higher stimulus or if you train them, they get better. And if there is a preferred visual field, always present objects to the preferred visual field. Like this boy only had a superior field. So always try and present it to their seeing field. And visual array should always be simplified. And when you have children with simultanagnosia, in a say in outdoors, they will always prefer approach magnification. While you're reading and all, you can give simple one optotype and reading guides and all that, but when you're in the outside world, they'll try to go close to it. That is a coping mechanism. Don't stop them from doing it. Typically parents will tell they're going close to the TV and watching despite having a good vision. Don't keep pulling them up behind, because they're actually using approach magnification to cancel out the simultanagnosia. Sensory integration, when you mean vision, don't keep saying you have to see and you can't hear or touch. It should always be augmented by auditory as well as tactile, and that is how children learn visually mediated concepts as well. Who all should be referred? Any child with any insult to the growing brain, preterm, STOMI neonatal course, ROP, developmental delay, very poor attention, learning disability, everybody has to get a evaluation. Neuroimaging may be diagnostic value, but a normal MRI does not rule out CVI. Whatever you see in the MRI need not really correlate with the severity of CVI. Etiology of CVI may not correlate with severity or presentation, and CVI may manifest itself in unfamiliar environments. In home and in school, they may not have simultanagnosia. If you put them in a mall or in a new park, suddenly simultanagnosia will come, facial blindness will come. You cannot take for granted that a child, the same way they were in office, they were going to be there in the entire day-to-day life. So in new places, when there is stress, new problems, new functional disabilities will keep popping up. Plasticity in childhood is limited. Do not take for granted that it's a younger child, they will always improve. This is a compromised brain, and plasticity is always limited for you. And to summarize, functional vision is very important. Distance of communication should always be mentioned along with the contrast. Intervention, do not forget on multidisciplinary referral. If you don't know where to start, always work on the developing visual milestones. See up to what they have achieved, and from there start your rehab. And always remember that early intervention and cross referral are crucial to CVI. Thank you so much.
Thank you so much, Dr. Sahitya. Now I call upon Dr. Sujata Guha ma'am to talk about preventing and managing visual axis opacification after cataract surgery in children.
Good morning, everybody. At the outset, I would like to thank ARC and AIOS for this opportunity. Now, visual axis opacification is one of the most common and important complication of pediatric cataract surgeries. And if you leave the posterior capsule intact, the opacification rate is 100%. If you remove the posterior capsule and retain the anterior vitreous or the anterior hyaloid, the opacification reduces by 60%. And if you remove both the posterior capsule and the anterior vitreous, the visual axis opacification reduces by 6% to 6%. So with this background, let me focus on a few ways of preventing visual axis opacification. One of them will be very copious hydrodissection and intraoperative polishing. If you are leaving the posterior capsule behind, these two will reduce the burden of lens epithelial cells and will leave lesser epithelial cells to migrate and cause visual axis opacification. The next key thing that you can do to prevent posterior capsular opacification will be doing a posterior capsulotomy. Here the sizing of the capsulotomy is important. 3.5 to 5 millimeter would be a safe size to prevent a membrane from forming. And you can use cutter or a rhexis forceps to do it. Again, as I stressed, anterior vitrectomy can also reduce the visual axis opacification. And last but not the least, an optic capture, which is nothing but pushing the IOL optic behind the posterior capsule to reduce, again, to cause fusion between the anterior and posterior capsular lip and reduce the migration of the lens epithelial cells into the anterior hyaloid. Now, the lens design and material is also important. So if you are leaving the posterior capsule intact, a hydrophobic lens with square edge can reduce the posterior capsular opacification. And post-operatively, copious steroids with a good cycloplegic agent can reduce inflammation and thus cause reduced PCO. Now, the preferred practice for doing a posterior capsulotomy is that till 6 years of age, you will do a posterior capsulotomy with an anterior vitrectomy. From 6 to 8 years, do a posterior capsulotomy, you need not do an anterior vitrectomy. And in children more than 8 years, we usually leave the posterior capsule intact. However, this is not, the age is not a watertight thing. You should treat the patient and not the age. So in patients with developmental delay, in patients with traumatic thick fibrous capsule, patients with nystagmus and patients who will not be able to sit and keep their face in a YAG laser machine or will be unable to come for follow-up, you can consider removing the posterior capsule and doing an anterior vitrectomy even in older children. Now, once you have a visual axis opacification or a posterior capsular opacification, how can you treat it? ND-YAG laser, of course, is the first choice. But in children, lasers have a recurrence rate of almost 30%. So these children will come every summer vacation for a posterior capsulotomy. And usually the lens epithelial cells proliferates along the anterior hyaloid and thus causes visual axis opacification. And if usually these opacifications are thick and they might not be cut with ND-YAG. So in that case, you need to do surgical membranectomy. In aphakic children, we usually prefer membranectomy through the limbal approach. In pseudo-aphakic children, we can use either the limbus or the pars plana. Now, in certain special situations like persistent fetal vasculature or anterior PHPV, when the capsule is very thick, we will cut the capsule definitely and fashion a posterior capsulotomy around 3.5 to 4 millimeters and then slip in the intraocular lens. In inadvertent PC rents in children while polishing, we can actually convert the rent into a CCC, that is a continuous rhexis, and then do vitrectomy and place the lens in the bag. In high myopes is an exception. We actually don't touch the anterior hyaloid because risks of retinal detachment are rather high. So if it is a very small child with a high axial length, we prefer doing a posterior capsulotomy and not disturbing the anterior hyaloid. And if they're at a very high risk with other eye having retinal detachment, we sometimes leave the posterior capsule intact even though the child is very small. In patients with coexisting posterior lenticonus where the posterior capsule is already open, we can fashion the posterior capsulotomy with the cutter with adequate sizing and then slip the lens into the bag. And in post-vitrectomized eye with silicone oil, usually the posterior capsule again is fibrotic and thick, so we need to remove the posterior capsule even if the age is older. So to summarize, if you are leaving the posterior capsule behind, doing a good hydrodissection, polishing your posterior capsule will reduce the chances of posterior capsular opacification. In children below 8 years, you should remove the posterior capsule. You may or may not do anterior vitrectomy in slightly older children. But beyond 8 years, you prefer to keep the posterior capsule and the anterior hyaloid intact, thinking that you can do a posterior YAG laser capsulotomy except in special situations that I mentioned. Thank you.
Thank you, ma'am, for your wonderful videos and tips. Now we go on to the last talk of the session by Dr. Anupam Sahu in managing intermittent exotropia.
Okay, thank you for this opportunity. So intermittent exotropia is one of the commonest form of divergent exotropia in children, but it still provides us with managing dilemmas because it, in these patients, they usually have periods when they have normal binocular functions and which are interspersed with periods when they have lost their fusion. So, and in some cases there are asthenopic symptoms mainly because they try to maintain their fusion or their deviation. When in those cases there are asthenopic symptoms too. So before we move ahead with the management, it's important to know the natural history. There has been a lot that has been worked upon in this, and basically today we know that there is no significant change in the mean exodeviation. Studies have shown that even up to 3 to 5 years after the deviation has been noticed, there is no significant deviation in most of these cases. Coming to the evaluation, so before we move ahead with the management, it's important to evaluate a few things. What would we like to do? We would like to know the visual acuity. It's very important to do a good refraction. Cycloplegic refraction is absolutely essential. Even for adults, you can do that if they have pseudomyopia kind of picture. Near stereo acuity is usually good, so it's not a very good criteria for managing. Ocular motility, we need to rule out any lateral incompetency because that has been shown to affect the outcomes. Near and distance disparity is an important finding in this. If we have near and distance disparity, then we need to do a patch test to rule out any divergence excess, and also need to do a AC by ratio, NPC, fusional convergence amplitudes, and near point of accommodation in these cases because they may be deranged. So once we do all this, we can classify our case into either basic type, a divergence excess, convergence insufficiency, or another thing that can be added is the pseudo divergence excess, where we have the distance more than near, but then after the patch test for at least 1 hour, we find that the distance is equal to near. Kushner basically expanded this classification, and so he added to that basically in those who have distance deviation more than near, a high AC by ratio. If those cases have a high AC by ratio, then that's one thing, and they may have a normal AC by ratio. And those who have a near deviation more than distance, then you can have fusional convergence insufficiency or pseudo convergence insufficiencies. We'll move to the management based on this later on, or a low AC by ratio again. So the Newcastle team of Buck and Haggerty, they then devised this Newcastle control score, which is basically an easy score. Any score more than or equal to 3, you can go ahead with a surgical option. But then there are other variants also to this. So this can be considered as a scoring score for your OPD. Then coming to the management, how do we move ahead with these cases? So we have the non-surgical options and the surgical options. The non-surgical options include spectacle correction, which is absolutely mandatory. Overcorrecting minus lenses have been suggested. I usually do not overcorrect as such minus, but then yes, for children who have hypermetropic spherical refraction, I usually give lesser of that. Part-time occlusion, the Paediatric trials have shown that part-time occlusion may be of benefit, especially in those children where we are not able to calculate the deviation appropriately. We can go ahead and do that. That has been shown to be comfortable, at least improves some amount of it. Orthoptic exercise, especially in those who have convergence insufficiencies, and prisms only for those in which we cannot actually go ahead and do other cases. And then you have the surgical options. I'll leave aside Botox right now because it's not yet, there is no sufficient evidence to suggest that. So for surgeries, when would you actually like to go ahead? When there is serial observations documenting poorer control, when there is an increase in size of the deviation, when you notice that there is a progressive reduction in stereo acuity, if you can measure the distance, that's a best thing for that. Or if they have asthenopic symptoms, especially in adults, many a times they try to control their deviation, and when they relax, but that's the time when they have actually blurring because of accommodation. So those are patients who are actually having lots of asthenopic symptoms because of intermittent exotropia. And so what do we do? Once we decide that, okay, we need to manage this case, you need to, you can actually go ahead and do it by Kushner's classification. For basic, we do surgical options. For tenacious proximal fusion, you again have surgical option. If the patient has a high AC by A ratio, then you can start off with overcorrecting minus lenses, and over that you need to add bifocals. And even if you decide for a surgery, it's important to tell that for near, the child may need bifocals later on. Proximal convergence, surgical. If the patient has a low AC by A ratio, and if you have calculated that, then that has a very guarded prognosis. Do not try to touch those patients as much as possible. Fusional convergence insufficiencies start with convergence training, and so these are the main parts. So majority of the cases are usually your basic and tenacious proximal fusion kind. So coming to the principle, so timing of surgery, as I have just stated, that the control is what will define the timing of the surgery rather than age. However, if you actually want to know something, then this study has shown us that maybe 7 to 12 years of age would be a good time to actually operate on these cases. For younger children, we usually see overcorrections, and for older children, we may get undercorrections. Type of surgery, for basic type, again, studies have shown that there is no significant difference between both these types. You can go ahead with whatever you are comfortable with. For others, as I've suggested, we can go ahead with, for example, if it's a proximal tenacious fusion case, then you can actually go ahead with a bilateral recession in those cases. Amount of surgery, this is very important, because we'll come to the outcomes later on, but then you need to operate on the largest deviation that you have ever measured. You can do prism adaptation, you can do a deviation after 1 hour of monocular occlusion to get the proper deviation. And some have suggested augmented lateral rectus recessions of 1.5 to 2 millimeters. You can go ahead, but remember that the AIOX group has suggested that 40% of those who have been initially overcorrected remain so by the last postoperative assessment. So I don't usually do that. And coming to the long-term outcomes, they are, if you look at their initial presentation, they are not very good. Only 38% had excellent motor plus sensory outcome after 10 years, and around 60% needed reoperations. And isometropia, lateral incompetence, or immediate postoperative undercorrection are things that you can look out for poor outcome. Thank you.
Thank you so much. So we'll have a discussion starting from the current talk. Like, I want Dr. Pradeep Sharma sir, like this, probably AIOS is one of the most challenging and in fact even frustrating condition to manage for all strabismologists. What is your threshold, sir, to surgery, like to operate?
So it depends on if it's a child or an adult. So in adults, I think we will be having a lower threshold, because if they are having a manifestation, you want to correct, and even we may do a little bit of overcorrection of 8 to 10 prisms. In children less than 4, we try to see that if they are full-time manifest, then only we operate. If it's an intermittent, I try to delay and see, and I find near stereopsis also useful. Distant stereopsis may not be available to most people, but near stereopsis, I think it's important to do for each and every person. Not only for ideas, but even for other people. I think always test the stereopsis. Stereopsis is your basic thing. So, and if you find the stereopsis is good, you can delay the surgery if you find that is there. So the threshold would depend upon the age and the times that you find the manifest part is there.
The distant stereopsis.
Distance stereopsis, as I said, may not be available to most people. I mean, it's only in some institutions-based practice that will be there.
Actually, Binox has a distance stereopsis. Do you find that useful? The Binox comes with a diagnostic module.
Yeah. No, but Binox is like you would be having Binox with you at your clinic.
Yes.
Okay. So then it's a different. I'm not aware if that is there. Binox is providing you, or is it like it's a paid service at home? I thought it was
free service.
Okay. So then you can use it. I don't know exactly how much is the validity of that Binox distance stereopsis. One has to check that. It's based on red and green basically, no?
Yes, yes.
And it's based on TNO?
Yes, kind of. Yeah.
So then you can use that. The distance stereopsis would be fine. Because we found when we were in AIMS, we did a study that distance stereopsis is affected earlier. But even in US, most people are not using distance stereopsis. It's only in few places that they're using.
Mike.
Okay, so I'm not aware. Okay, so one needs to check. Maybe you can validate it. You can check it. Do a study, compare it.
Comparing it.
Both. Yeah.
We actually don't have other distance stereopsis tests. So somebody with other distance stereopsis.
I had a question for Dr. Aruna. I mean about the organic amblyopia, which perceptual learning studies you have found useful? I mean, are there any published thing?
Center, and we do see some low vision patients.
Mic on.
On the mic level.
On the mic.
Understanding.
So mine is like I work in a glaucoma center, Dr. Satyan sir. So we see a lot of retina and glaucoma patients with low vision. Actually, organic amblyopia is something where there is an organic cause. So we have tried. I don't have too much of experience on that, but tried for a girl with congenital glaucoma and 2-3 patients with macular dystrophy and scars.
I would be curious to know, is it that it's because of time, the children have grown up, the visual acuity is improved, so you are giving the credit to the perceptual learning?
Yeah, it's all in adults actually. So this organic is something, there is a pathology.
So
right?
they have improved with which perceptual learning? Geber patches one?
No, yes, Geber patches, because that's the only treating available, and for adults and for low vision. Yeah, I have one person with macular dystrophy. She showed a bit of improvement. I would say 1 line and not much of. I think the other 2 are still on therapy, so I just need a lot.
I was curious because this is a preferred practice pattern. I mean, I was
one of this congenital glaucoma child, she was operated soon after birth, but she's a 19-year-old now. She's a one-night patient. She has an artificial cylinder. So she was keen, because she's a college student, she was keen to improve her vision, and she's ongoing the therapy. But the only thing what we have found is with the Geber patches, she's finding it difficult to do the task, but still she's trying it.
It's working, it's good, because I had little doubts about the Geber patches thing.
We have to see how it works, but since there is no, we thought we'll just, it's a like a visual task which has to be done in challenging cases.
I also had a question. What is the better practice in ambulatory therapy in adults more than 18 years? Are you doing it for the refractive amblyop? Are you doing it for the presbyopia, or for both?
For all the amblyops, I would say, but both with dichoptic training or perceptual, but after you correct the strabismus part, everything. For all amblyops I do, but I feel refractive amblyops have the good prognosis. I have treated sensory deprivation amblyop, but not. No, strabismus and sensory deprivation, no. I would say they are not a good candidates, but for refractive amblyops, yes, they do well, even in adults.
Dr. Arun, I have a question about myopia treatment. What is your take on treatment of, usage of first treatment, like DIMS as a first line, like as the patient comes to you at the first visit itself? Is it okay to start DIMS?
I've never started on the first line of treatment. I always follow up the patient at least for 6 months.
Atropine, we never start that like that unless we document progression along with that. But DIMS, we see people already starting at this.
I think it's more than the ophthalmologists, is the opticians who are very eager to market that and sell them. So they aggressively promote that, and I just suggest a normal glass, but they come back with the DIMS glass. So that's unfortunate, but I normally don't do it as a first visit at all. In fact, I don't do any treatments in the first visit unless there is a documented progression with the previous. Yes.
Maybe I
glasses within 6 months. Most of the young children, the glasses don't last more than 6 months. They are scratched or they're broken. So DIMS, when you talk to them, it's very expensive for them to kind of use. So yeah, how a optician convinces them is, it's difficult. The same here. I find more opticians giving DIMS than us.
We are. They are better in sales than we are. But
Maybe
I think there is a little bit of, I have a little slightly different viewpoint on this. That's why that risk profile is very important, which I think you also mentioned.
High risk group probably.
High risk group, younger children who both parents myope.
Siblings myope.
Siblings myope, then probably it's rather than atropine, which has a little bit of gap in knowledge, I would rather put DIMS or something, which you are likely to anyway progress.
Because now parents are very, they want some treatment. They read a lot and they want something to be done even at the first visit. So
May
I
not
kind
be
of
exactly at the first visit, but I will follow them up more closely.
first 6 months,
First 6 months.
at least 6 months. Yeah, yeah, probably then we can, right. It's not justified, yes.
And what do you do with children less than 4 years who are coming with very high myop? Say 6 years, 7 years, 6, -6, -7, -8 at age 3. No, bilateral. The bilateral myopes in a small child, less than 4-year-old.
You have
It
ruled
is
out
coming progressively more often these
syndromic,
days.
No? No syndromes?
So even before 4 years, are we starting the low dose atropine? So we do not know congenital. We know that they are not ROP. They are normal kids at term babies coming with very high myopia at age say 2.5, 3, progressing. Would you start or would you wait?
Wait for a year. That will, because if you see it's a progression, then probably it's time to start low dose.
I think combination therapies will work better. They don't respond that well to drugs also.
Exactly.
Yeah, so I want to just add one thing, that when you have these children coming very young, below the age of 4 with very high myopia, it is unfortunately happening. Of course, you'd ask the usual risk factors of family history and all. Also not a bad idea to check about screen time, because sometimes parents are giving even very young children
they
to
feed
learn.
Absolutely,
And
that is
also
one
eye
of the
rubbing.
responsible
So,
things.
sometimes you can get keratoconus also because of eye rubbing, or there may be allergies. So it's a good point to have a discussion about these alternatives with the parents, so the parents don't feel that the ophthalmologist didn't give us that option. Parents are going to check it up on Google, they're going to go here and there. So you have a discussion and you say, for example, we often have this with cross-linking also. So I always tell the thing, this is my philosophy that I prefer to watch. But if you're not going to come back, then we can give you the treatment straight away. Sometimes the parents feel that, you're a better person to advise than the optometrist.
Finally, you're right. That's a good point. Thank you, ma'am.
Yeah. I tell them. No, they use us. I mean, we let them use us. Yeah, use me, terrorize using me. Yeah, no problem.